Hello and welcome to this next in the series of the Royal College of Pathologists Guideline Implementation webinars. My name is Peter Johnston and I'm the Vice President for Professional Practice in the College. It's a great delight for me today to chair this webinar, and we have some leading experts to introduce the dataset for histopathological reporting of colorectal cancer. And the purpose is to show the new elements of the data set in the current revision and to clarify some aspects to help implement it in the form of some practical advice coming forward. I'm very grateful to Professors Maurice, Loughrey, Phil Quirk and Neil Shepherd, who have put together this guideline, and I'm delighted that Maurice and Neil are with us today to present the data set to you. Before we start the webinar, just remind you the ground rules, as it were. The presentation will last about 15 minutes, and then we have 20 minutes thereafter for questions and answers, finishing at 1:45. If you would please ask your questions on the Q&A session. All participants are muted and will remain muted, so the questions will have to come through me. But if you just write your questions down, we'll bring them over and try and pull together some themes as we go. So without further ado, I'm delighted to hand over to Professor Maurice Loughrey, who's going to talk to you now about the guidelines for histopathological reporting of colorectal cancer. Maurice, thank you very much.
Thank you very much, Peter. I assume you can all see and hear me okay. Do let me know if there are any issues. But it's a pleasure to deliver this brief introduction to the new colorectal cancer dataset revision on behalf of myself, Professor Phil Quirk and Professor Neil Shepherd. Unfortunately, Phil was unable to join us today, but Neil is here and we'll together field questions and hopefully have some helpful discussion on any detail or any issues that I don't cover in the talk or that require further discussion. So this is the document published in April of this year. And given that I only have 15 minutes to describe the data set, I'm just going to focus on those changes from the last version. So there are some issues I'm aware of, difficulties in implementation that we may address during the discussion phase of it, but really haven't changed from the last version. So for example, tumor deposits is an obvious one there where I think that can cause problems to us clinically, but nothing really has changed from the last version of the data set. So I won't invest a lot of time on that in the lecture part of this. So there's 15 points really that have changed. Again, the color scheme here is some of these are very straightforward, just small additional details or changes that are really self-explanatory from the text. So I'm going to invest time in those in green, where I think these are problems that have come up either post-publication or maybe during the consultation phase where we've tried to address them in the final data set, but I think some further guidance might be helpful. So to kick off, desirable clinical information, really here, this is something I guess that's probably more aimed at the clinicians who of course don't really read the college data sets to the same extent as pathologists, but we can maybe try and help encourage them to provide more information. Here I'm thinking about when they provide, say, an en-bloc resection of abdominal wall, and it's very useful for us to know about that in advance of dissecting the specimen. In fact, if we don't know it, it can be just too late to go back later on, and that has obvious implications for assessment of T-stage and margin status. There's a few minor changes around how to assess maximum tumor diameter, not a major issue for colorectal cancer as tumor size doesn't impact on staging. So again, that's one probably just for a look at the text. And use of the term tumor perforation is the first one I want to go into in some more detail. So we've defined this as macroscopically visible defect through the tumor such that the bowel lumen is in communication with the external surface of the resection specimen or with the lumen of another organ. So we know certain things for a long time about perforation. It's a well-known prognostic factor. If we have perforation into the peritoneal cavity, that's obviously an adverse feature. This is distinct from perforation proximal to the tumor, which, as we know, doesn't impact T-stage, but is an independent adverse feature clinically. So the issue is around where we get what might sometimes be called a perforation, but it's really like a clinical perforation or intraoperative full thickness defect, maybe to use a better term, where if you see a hole in the tumor, but it hasn't arisen biologically, rather through the actual surgical process, or maybe increasingly, I think we see this because tumor splits during extraction at laparoscopy. So we basically have something that's quite biologically different and requires different handling. So we've given some guidance there as to what we think we should do in that context. Specifically, if the defect occurs while the specimen is still within the abdominal cavity, that should be regarded as PT4A disease. But maybe if the clinician convinces us that it happened out with the abdominal cavity, it shouldn't influence T-stage. Bottom line here is be aware of the different uses of the term perforation, and clinical pathological discussion is required for appropriate classification. Okay, back to the list of changes. So the next two are around the WHO classification of tumor typing and assessment of grade of differentiation. And I want to address these two together. So just in brief, we endorse and recommend the 2019 WHO classification of histological subtypes. And we're aware of and familiar with most of these, but I think we probably underreport medullary, serrated, and micropapillary adenocarcinomas. So just to flag and be aware of the definitions of these. For example, we only require a minor proportion of an adenocarcinoma to have micropapillary features to label the whole tumor as such. And importantly, only a small amount of micropapillary features is associated with the adverse connotations of that subtype. So that's just one example, but do use that WHO classification and the rarer subtypes that we don't have time to go into today, but that's really our go-to for typing. Then grade of differentiation. For a long time now, we've used a two-tier approach rather than the previous three-tier, and this is based primarily on gland formation, less so cytology. It's applicable to adenocarcinoma, NOS, and mucinous subtypes, but the other subtypes really have their own prognostic implications based on type, so we don't need to formally grade those. The big change, though, is that we now base differentiation on the worst area rather than the predominant area. So this is a change made without good evidence, but for pragmatic reasons to allow us to be consistent with WHO and ICCR, and also to be consistent with ourselves in terms of we previously used worst area for local excision specimens, PT1 cancers. Now we're aligning this, and I think this is important because increasingly we're seeing more aggressive local excision therapies where maybe we can get a PT2 tumor within a local excision, and we can't really have a change in the approach to differentiation as soon as tumor infiltrates into muscularis propria. So we'll see one of these specimens later, but just a couple of other practical points. We need to ignore tumor buds and poorly differentiated clusters of the invasive front when assessing differentiation, and there is no minimum area required. So we thought about introducing, for example, a 10% rule, but again, this would have been done without evidence and so prone to criticism. So all I can offer there is to say if there's any significant component, whatever significant might mean, a significant component of poor differentiation, that's how we should label the whole tumor. Okay, back to this list. So we've also tried to provide some additional detail to assess T-stage and margin status in a few specific scenarios. I'll come back to that, but just to mention briefly and pass on, it's important to mention regression in lymph nodes if we see that. So we base tumor regression on the primary tumor traditionally, but I think it's important to me, we often get asked, if it's not mentioned in the pathology report, was there any evidence of regression within lymph nodes? So it's not enough to say nodes negative or positive. We're very, oncologists in particular are interested. Are these negative nodes, do they show evidence of regression such as fibrosis or acellular mucin? So that's important. Tumor deposits, as I mentioned, can be difficult. We've offered some additional detail there, but nothing really has changed regarding how we're meant to interpret those under TNM8. Then regarding the specific scenarios, just to flag this, I think very useful publication involving Neil, Newton Wong, and others, where specific scenarios cause problems for pathologists in reporting. So we've really tried to address everything that was brought up in this study and certainly clarified anything where there was lack of clarity before, and really introduced or go chasing some guidance in areas that we hadn't previously considered. One of these, I think, very importantly, is around acellular mucin. So I think this requires specific highlighting. So we're very familiar with interpreting acellular mucin post-neoadjuvant therapy, but it's much more difficult if the patient is treatment naive, if they haven't had any such therapy. How do we evaluate acellular mucin in terms of T-stage, end-stage margin status? So there's a very limited evidence base around this because there just aren't that many cases that where if you don't look hard enough, you can't find cellular mucin, but you do occasionally find only acellular mucin at a margin or only acellular mucin beyond muscularis propria, or very, very rarely only acellular mucin within lymph nodes. And in the absence of a good evidence base, again, our aim here has been consistency with these other organizations. And I think very importantly with other RC-Path data sets, in particular the appendiceal data set, which has emerged in recent years. So we've really aimed for consistency there. And the guidance we've come up with is that if a patient hasn't had previous treatment, that acellular mucin should be the basis of stage. So if you see it beyond muscularis propria, that's PT3. If you see acellular mucin within lymph nodes, that should be regarded as at least PN1. And if you see acellular mucin at the margin, again, that's at least R1 margin status. As I say, this is offered without strong supporting evidence, but does aim for consistency with other agencies. And obviously, explanatory notes indicating how you've arrived at that assessment is important. Okay, moving on then to venous invasion. So for a long time, we've been using the Talbot definition of venous invasion, but we've slightly changed or eroded this over the years, and we've made a further change. So just to go into this in a little more detail. So the original Talbot definition included a mention of red blood cells and included also this endothelial lining. And we're aware that we can see red blood cells often within lymphatic spaces, so that can be misleading. So we've removed reference to red blood cells in the definition. And also, and I have to flag some of the consultation responses we got were very useful here. It was pointed out to us that often we see tumor completely obliterating the vein lumen and we don't see any endothelial lining, and therefore we can't really rely on that in all circumstances for defining venous invasion. So we've taken that on board and we've changed the definition to indicate that around a tumor nodule with a rim of muscle or identifiable elastic lamina is also enough for venous invasion. So this may, of course, need ancillary stains, but I think the important message here is that, so for example, if you see the orphan artery sign, that alone is not enough to call something venous invasion, but you should certainly chase that with deeper levels, ancillary stains, and then the judgment call becomes one of, do we see convincing features of a remnant vein wall or not? If we do, it's venous invasion. If not, we're into tumor deposit territory. The additional investigations section has been expanded for molecular pathology purposes, really, and that the representative tumor block, we now specify that this should be a block useful for molecular testing. So we're trying to encourage pathologists to select the block with most tumor relative to normal non-neoplastic content, inflammatory cell necrosis. So we also want an estimate of the carcinoma cellularity. So based on the total cellularity of the block, what's the percentage of neoplastic nuclei or carcinoma nuclei to be more specific? And this doesn't have to be very precise, but what we're really looking for is encouragement to identify the block with the highest such percentage, because this is very useful information for the genomic hubs or genomic labs that we deal with. If you have a greater than 50%, for example, carcinoma cellularity, that means that they don't have to do macro dissection for most of the assays that they're chasing. Okay, and in the last few minutes to move on to local excision specimens, perhaps the biggest change in the whole data set is the move from tumor budding in PT1 colorectal cancers from non-core to core status. So we're now expected to grade tumor budding in all local excisions that have PT1 tumor within. So this remains a non-core item for surgical resection specimens pending further evidence. And I think it's probably a lot easier to assess budding in the local excision. So that's something, a good place to bring it in and see how we get on with that. Just briefly, this has been in the pipeline for a long time, very strong evidence and numerous studies presented here in this meta-analysis from 2021, showing very similar odds ratios in those that contribute the most weight to this meta-analysis of around 3 to 4 for prediction of lymph node metastatic disease associated with high-grade budding. One of the problems delaying bringing it in was lack of agreement on how we should assess this. That's now addressed from this 2016 consensus conference, where this method is now fairly well established, looking for the budding hotspot in the 0.785 square millimeter field of view, which of course may need normalization depending on the microscope in use, or if you're taking a digital approach to just make sure that's the area you're dealing with. A few practical points that I was keen to include in the data set, having tried to put this into practice personally. So very important that we should assess budding or avoid assessing budding in areas of active inflammation or in association with gland rupture, as these clearly represent a different biological phenomenon. Similarly, we shouldn't look for buds in areas of mucinous differentiation, but you can assess budding if there's a minor conventional opponent within a mucinous adenocarcinoma. And finally, we can use cytokeratin immunohistochemistry to bring us to the field of highest budding. And I think this is very useful practically, but you must be sure that it doesn't bring you to a field of inflammatory cells and rupture. All of these things may lead to increase in appropriate budding score and overgrading. So it's important to be aware of these caveats. Then maybe helpfully, we only need to assess budding at the advancing tumor edge. So you don't really need to pore over the whole tumor, just focus on a line defining the advancing tumor edge and look for buds in there. So just as illustrated here, for example, if we restrict the budding evaluation to the area of the yellow line, we can see that that's where we must assess buds, and we don't need to go into the whole of the invasive component. So we basically scan, we look for the highest hotspot, either on H&E or immuno. And here, for example, I think I can see 5 buds, so that brings us into the grade 2 territory. So again, just to be aware of the cutoffs between grades is important. And here, for example, there's another bud just out with the circle. And I think if I shuffled up my field a little bit, I could have probably squeezed that in as well. So maybe 6 would be probably a truer reflection, but just to be aware of the important cutoff points. So that's tumor budding. Sorry, just one more image to just show that cytokeratin can be very useful in highlighting local excision specimens. Just to mention briefly that these are getting more ambitious, as I said earlier, and importantly, if we encounter the endoscopic full thickness resection specimen, that's something where we need to apply a little bit of caution. Importantly, what we're looking for here is representation of muscularis propria, hence the term full thickness, and this may or may not be all of the muscularis propria. So here we see a tangential section through the muscularis, but clearly some connective tissue beyond. Regarding margin status here, we see that the tumor is into muscularis propria, so it's PT2. We don't have any nodes in the specimen, obviously, and the margin's clear by a couple of millimeters. So we may be expected to provide this level of information and detail. And if there's margin involvement, for example, it's important to indicate which plane we're dealing with. And then finally, we've added some comments on reporting diagnostic specimens to hopefully help that area. And last but not least, we have recommended an increase in the median number of lymph nodes should be harvested for audit purposes, an increase from 12 to 15. Okay, that's my time up. I am happy now to field any questions with Professor Shepherd. Thank you.
Thank you very much indeed, Maurice. And it's a really interesting tour through that data set. It's actually quite a lot of material, and well done for covering all that in very quick time and fully. Thank you. Please remember that we are delighted to receive questions, and what we have to do is to send the questions in on the Q&A. And I haven't got any questions as yet, so while you're doing that, I might just ask one about peritoneal involvement. You mentioned peritoneal involvement, Maurice, earlier, and I think Neil was going to take a question while people are thinking. So about peritoneal involvement, Neil, do you think that we overestimate peritoneal involvement or underestimate it?
I'm pretty sure we underestimate it, Peter. And I've had a few contacts with various people who are struggling to get to our rate and recommended in our audit standards of 20%, which I know is a relatively low number. In the original publications on this that we did from our Gloucester series, our rates were up at about, this is just for colonic cancer, and we're satisfied that we shouldn't have a rectal cancer as part of our audit figures for peritoneal involvement, because numbers even in Gloucestershire were very low. So we had rates up at about 45%, and I think there's one major issue that we need to look at here is how the specimen is assessed. And I have no doubt that you are most likely to see peritoneal involvement in the crevices of peritoneum-lined spaces between sort of fatty lobules, and you are less likely to see it on the flat peritoneal surface, particularly the one that you look at as you turn the specimen over and look at the peritoneal surface. So directing your blocks here is just so important. And I think the people who aren't getting high rates of peritoneal involvement, it's all about the macroscopic assessment rather than microscopic assessment. And critically, it's where you take the blocks from. And I think the idea, we might come on to macro blocks, but I have a bit of an issue about macro blocks. I don't like them. And I think there's a great danger of people who take macro blocks are just saying, right, there's my blocks of tumor. And they're not looking terribly careful at the particular features, like the demonstration of extramural venous invasion, which the radiologists can see, for heaven's sake, in their studies. So we can see it. And I think there's a great danger with macro blocks of just randomly taking tissue and not looking at it very carefully at the macroscopic assessment. So I'd say that certainly for extramural venous spread, or for venous spread in general, and I'd certainly say it for peritoneal involvement. You get higher rates if you direct your block taking at areas most likely to show it.
Thank you. Some controversy around that because macro blocks are very popular. I personally don't like them either. Not that I do colorectal stuff, just because it clogs the lab up. But and
you can't do you can't do all the immunos you have to do, Peter, on your lymphomas. Yeah. Correct.
That's the issue. So we've now got some questions coming in. So the first question is really about differentiation, and you mentioned differentiation, Maurice, and the question simply is, what constitutes a poorly differentiated cluster, and how do we use, what are the criteria we use to define that when we're actually picking that as the diagnostic statement? Yeah, I don't know. Do you want to answer that, Maurice? Thank you.
I'll handle that if that's okay. So poorly differentiated clusters are a very specific term. I mean, simply put, they're really large buds. So essentially, they're clusters of tumor cells that are more than the 4-cell cutoff for a bud. So you have 5 nuclei or more, and there's really no upper limit. These things can be quite big, but they lack a gland lumen. So they're basically balls of tumor cells. And I think the best way to get your head around what they look like is to think of a micropapillary subtype adenocarcinoma. So I tend to think of that as really the kind of the exemplar of what PDCs look like. So there's actually quite a bit of interesting literature around PDCs versus buds in terms of grading. So they haven't been around as long. They're definitely easier to see because they're bigger and you don't mistake them for inflammatory cells. And there's some evidence to indicate that grading by PDCs is actually of more clinical value than grading by buds, probably because of the issues around inflammation that aren't quite as big a deal for PDCs. It's not nearly as mature an evidence base as exists for tumor budding. So we certainly haven't gone there yet, but it is in there as a non-core item, and we'll be kind of watching this space. But the same meta-analysis that we showed, it only had about 4 or 5 studies looking at PDCs, but their odds ratios were actually much higher. But there's a huge literature out there on it, and essentially they look like large buds, the kind of micropapillary features that you would see. Maybe one other comment on that, because it's something that get asked in other circles. So if you just see buds or PDCs at the advancing edge, then we're meant to discount those for the purposes of overall grading of the tumor. But when you get more extensive, and again, it's a bit subjective, but if the PDCs that you're seeing are beyond the tumor edge, so if they're kind of more within the body of the tumor, then you're into probably something that's either poorly differentiated or micropapillary, in which case differentiation is not applicable. So there's all sorts of gray areas there, and the heterogeneity that tumors in general and colorectal cancer in particular, the heterogeneity that they throw up causes us all sorts of problems with assessing grade and so on.
Peter,
Thanks,
can I
Maurice.
just
Neil, yes, please.
Can I just follow that up by saying there are now 2 or 3 papers that we're aware of where they're looking at prognosis in polyp cancers, showing PDCs to be significant in multivariate analysis. So I think whilst we've included budding in the local excision data set, I think in future we might see PDCs there as well. 2 or 3 papers showing its prognostic significance in polyp cancers.
Thank you. Just to continue with the idea of grading and the biological significance of bits of tumour. During the presentation, Maurice, you mentioned that you use the worst area for grading. But there's a question that I've got, which is, it relates to this, but sort of indirectly, and it's around molecular studies. And so when we have an adenocarcinoma, do we send for, if we're sending tissue for molecular studies, do we use the worst piece, or how do we choose which piece we should be sending for molecular studies?
Yeah, that's a great question. I don't think we've really gone in, I mean, to try and suggest that we should seek, I guess biologically it might make most sense to go for the least differentiated component, similar to if you have it available, it probably makes sense to go for the metastatic disease, so the clone that's actually managed to escape the primary tumor site. We haven't gone that far. I mean, I think in practical terms, certainly in my practice, we try and test the initial endoscopic biopsy sample for the very pragmatic reasons that we might be more likely to have the results back by the time of initial MDM discussion. And clearly there's no opportunity there to select a worst area or not. There is, I think, pretty good concordance even between primary tumor and metastatic tumor around important biomarkers like RAS status. So I don't think there's a major driver for the problematic setting of using molecular phenotype based on, say, endoscopic diagnostic sampling to drive the clinical decision making in somebody with metastatic disease. So we don't say you must sample the MET to make sure that we know the patient is still RAS wild type in their metastatic disease before you give them anti-EGFR inhibitor therapy. So we haven't gone down that line basically, and I think we're some way off that. But yeah, if I'm trying to pick it, I think a big thing regarding the molecular block is more around asking pathologists to just think a bit more about what they mean by the representative tumor block, because in the past, certainly now, maybe this is a long time ago, maybe people are not doing this anymore, but we might have been inclined to pick the block that showed the venous invasion or pick the block that showed the PT4 disease. And I think that's important to, in a complete report, to maybe indicate that in free text or after those specific items. But the molecular block is something quite different. It's about purity and quality of the tumor tissue, and so that we can extract the highest purity and quality of DNA for further genetic sampling. So I think that's where we're going with that, rather than specifically targeting areas of worst differentiation.
Okay, thanks very much. There's a couple of questions actually come out which tie quite nicely with what you've been saying. The first, you mentioned metastatic disease, and there's a question about R2 status. And the question is, could you clarify, please, because there's a quote that says R2 status reflects not only primary tumor resection, but also distant or metastatic disease. So how could you just expand on that a little bit, please, and clarify it for us?
Sure. So I think this is again an important point, and I guess this stems from the idea that we might have been producing pathology reports in the past that said R0, where a patient has clinically got liver mets that are still left behind. Maybe they needed their surgery because of obstructions or emergency surgery, and we're calling it R0, creating the impression that margins are clear and everything is out. So TNM and AGCC, they have taken a position quite some time ago that really the R2 status should be based on the overall clinical picture for the patient. Now, of course, we don't usually get a setting of if somebody has that emergent surgery and they have liver mets, we tend not to get a biopsy of the liver met to confirm pathologically that there is residual disease. Occasionally, we can do it, say, if you have a, say, peritoneal disease, where they have a separate specimen indicating a sample of residual peritoneal disease. I think there is an unusual circumstance where we can designate R2 disease based purely on the pathological specimen. I still think the surgeon wants to know whether their excision is all out. So I think it's important to kind of convey the information that allows them to answer both questions. So the specimen itself might be R0, but the patient that may or may not have distant metastatic disease, for example, the liver, that may or may not have been biopsied. So I think our use of the term R2 needs to clearly indicate whether we're basing it on our assessment of the resection specimen provided or evidence of metastatic disease that has been sampled. So that actually TNM and AGCC have rolled back on this a little bit and said that you can really use R2 in either status, but you need to make it clear what you mean by it. So we haven't changed it. We've sort of gone just to minimize confusion. I think we've stuck with that previous idea that we need to think about the possibility of this metastatic disease, but I think it's all about clarity in our reports.
Yep. Yeah, it is the primary purpose, isn't it? Being clear about what we're talking. You talked again that it's about practical aspects, and there's a question which is about the intraoperative splitting that you mentioned. The question is really how do you approach it in terms of assessing it and finally staging the tumour? Do you do it at the MDT, or do you provisionally stage it before the MDT and then confirm? Neil?
I have a very strong view on this, that we need to use the MDTM for for its maximum information, and I would suggest Dr. Jain there suggests that you should provisionally stage it first. I suggest you don't. I suggest you just write against that particular parameter, await MDTM discussion, because some surgeons have very strong views on this, and I think you'll only cause yourself and perhaps the patient some trouble if you provisionally do it. So I suggest that where there is difficulties like that, is always leave it and discuss in the MDTM. I mean, I love my MDTMs. In fact, it's going on right now. So one of my colleagues is doing it, but the colorectal one. But I have a very strong view that we should use that meeting to discuss important aspects like this. And therefore, I suggest we don't provisionally give that information. We wait to the MDTM and get that information at the MDTM. Indeed, I would suggest there's almost a point in not giving a data set at all until after the MDTM discussion. But most of the data items are relatively uncontroversial, aren't they? But this one is, and it needs discussion with the surgeon. And let's face it, the information you get at the time of the operation itself, and as we all know, our request forms tend to be completed by the operating theatre window cleaner, and we don't get the accurate information. I'm just writing a little article for the Journal of Clinical Pathology on this whole question, and I've suggested that I have much sympathy for a surgeon who's just spent 4 hours, either he has or the tools of his trade has spent 4 hours in somebody's pelvis, And I can understand why giving information to a silly pathologist is probably not his top priority, or her top priority indeed. So I think the MDTM is where we get this information, and we should use the MTM to its maximum.
Yeah, I think that's a very good generic point, is that you question the purpose sometimes of MDT meetings when all you're doing is ticking boxes. The purpose is to discuss the cases, and so that we can collectively get together to provide the best outcome for the patients. And I think it's a really important point to make. So thank you for that. I'd like to move on now. We've got three relatively practical questions, which are really quite detailed. So the first one is margins of clearance. So could you please clarify what you would call the minimum margins for clearance for EMR, ESD, and TEM specimens, please?
So this is one of the most controversial areas that. So for PT1 cancers, polyp cancers in particular, we did attempt through the bowel cancer screening program system to change the 1 millimeter clearance to a 0 millimeter clearance, and we're told we weren't allowed to until we had good evidence. You can introduce all sorts of things primarily, but if you want to change anything, you have to have evidence. So we weren't allowed to do that. For these, we're still in the quirk era of a 1 millimeter clearance, and that's not changing. But I think the most important thing is, and it's very well dealt with, or we feel, in the documentation, is how you define the margin. And you don't define the margin as those artifactual cracks that appear. The margin is literally the outside border of the specimen. And when you do that, a margin of 1 millimeter remains the way we assess it, or at least a clearance of 1 millimeter is the way we assess it. But I wonder, there's as I say, there's a lot of contradictory evidence in the literature, but I think one day we'll be using the actual margin. Maurice, any further views on that?
No, I agree with all that. I think there's certainly increasing evidence that, for example, if the only adverse feature in your locally excised cancer is margin involvement defined by the less than 1 millimeter rule, that really that patient rarely comes to harm. If there are no other adverse features, the chances of there being a nodal involvement in any subsequent resection specimen are very slim. So officially, we don't have a strong evidence base. Actually, some has come out from the Netherlands since publication of this data set. So we're kind of moving in that direction, and I certainly try and take a very conservative approach to this situation. I think it hasn't been asked, but a very specific problem area is around interpreting the diathermy zone. And I think it makes perfect sense, even if you have 0 millimeters, if you have tumor in the diathermy zone, often the subsequent resection specimen won't show any residual tumor locally because of the tissue destruction at the polypectomy site. And so maybe the biggest concern for me is when you get that sort of appearance is that you don't have a good view of the peritumoral stroma, which is where you're likely to see lymphatic invasion, tumor budding, PDCs, the things that are probably really important biologically. So any older studies, I think, that equated margin involvement to adverse outcomes, I think a lot of them were around that. They were slightly less certain about assessing these other features. But the bottom line is, officially, it's a 1 millimeter rule, but clearly that shouldn't be an automatic trigger to surgery if there aren't other features, and we need to discuss these carefully.
Thank you. You've kind of covered a question about the surgical clearance margins for polyp cancers in that answer, so thank you for that. There's a very specific question from someone, which is about the normalization factor, and the questioner says, my microscope's normalization factor is 1.210, and if I use the formula tumor bud count per 0.785 millimeters squared, that equals 5 per 1.210, which is 4.1. So does that mean BD1 or BD2? So I guess this is a very technical question, but it's about the practical application of what it is that the recommendations are saying. Can you answer, one of you answer that one, please?
Yeah, I'm happy to answer that one. So
Thanks,
yeah, that's my understanding of the normalization factor from the ITBCC paper is exactly what the poster has done. So essentially, if the normalization factor is above 1, then that means your field of view is larger than 0.785 square millimeters, and therefore the BUD score, if you want, will go down, as it should do, obviously, if you're looking at a bigger area. So exactly what they've done here. So in this particular example, if they can't find more than 5 BUDs per high power view in that larger field of view microscope, then really the patient hasn't quite got to grade 2. So 4.1 is not enough in that scenario, when they would really have needed to find a field with 6 to creep into the grade 2 category.
Thanks. Just a couple of quick ones, I think, to finish off. Certainly, this one. Do you have any advice on the staging of discontinuous tumours, so that we've got a tumour which involves the peritoneum, but it's within the fat wrapped around the tumour? So how do you count that? It's not a distant metastasis because it's grown right through. Almost the fat has grown into the tumour rather than the tumour's grown into the fat, if you follow me.
Yeah, I think you often get these in your lymph node harvest, don't you? These little nodules that show, well, if first of all, if it fulfills the criteria for peritoneal involvement, then it's peritoneal involvement, it's PT4A. And if it fulfills the criteria for a discontinuous tumor deposit, which at that site, I think it almost certainly will, because it isn't it isn't venous spread, or it's unlikely to be venous spread lymphatic. So it's that as well. So I think that's PN1C, PT4A. Or in fact, the other way around, PT4A, PN1C, I would say undoubtedly.
So I might just query one aspect of that interpretation, Neil, that if it's not continuous with the primary tumor, then the T stage or T category really, I think, is only based on the primary. So I would struggle if you have a discontinuous tumor. This actually came up in the ICCR discussion and was discussed at length, and I think we've tried to address in the data set, may also have come up in Newton's paper. And I think the interpretation which was reached in ICCR, and I think we've accepted the wording of it in the college data set, was that even though you can't base the T category on a discontinuous tumor focus, in other words, you can't up it to T4A because you're seeing tumor involving the peritoneum, if it's within that local, that regional zone, as it has to be to make us consider tumor deposit. In other words, if it was anywhere more distant, we'd be talking about PM1C disease, peritoneal mets. But I think I would say it still remains PT3 with tumor deposits, but with a note that it's likely to behave like PT4 disease, that clearly the patient is at the associated risk of peritoneal recurrence that we would associate with peritoneal invasion. Does that make sense?
Yeah, thank you. We are almost at time, so what I'd like to do is just there's one question which is about tumour budding counts and what's your experience on digital platforms, if you have any. And perhaps we may, if there's a short answer to this, we can handle it within the time, perhaps.
I do this on a regular basis, and yes, I mean, it depends on the platform you're using for digital, but there are generally solutions out there. In fact, it's quite pleasant assessing budding digitally. It's probably easier, I suspect, when you have the kind of area tools. It's a little bit a modification of the tool for assessing mitotic, counter-mitotic index that a lot of the digital platforms have. Okay.
Well, thank you very much. We're out of time, I'm afraid. And just to tell everybody that the webinar that we've just been listening to will be available on the college website soon, including the Q&A session, and it's a resource for our members and fellows around about the implementation of this guideline. The hope is that we're able to use the feedback we get to help develop further guidelines around this area. So please do look in on this in due course when it appears on the website. So all I have to do now is to thank Maurice and Neil for coming and delivering this webinar today, and also just to pass on our thanks to Phil for his contribution to the guidelines. I would also like to thank Cynthia Mitri and Maria Marrero-Feo, who have helped run this webinar today, together with Chris Pontello and the events team at Royal College of Pathologists. Finally, I'd like to thank all of you for participating, for providing your questions and your interest in this webinar. And that's all for today. And thank you all very much for coming. Thank you and goodbye.